Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I am joined by two guests, an amazing husband and wife duo, Drs. Jill Meyer and Jeff Hindin. Jill is a fellow in the International Academy of Dental Facial Aesthetics and completed a dental sleep medicine certificate at the University of Pittsburgh School of Dental Medicine. She also achieved diplomat status in the American Board of Physiological Medicine and Dentistry. Her practice focuses on pediatric care, early arch development, and airway-centric orthodontics. Jill's husband, Jeff, is an adjunct professor at the University of Pittsburgh School of Dental Medicine and teaches the continuum in sleep-related disorders and health solutions. He is also a diplomat of the American Board of Physiological Medicine and Dentistry, as well as a fellow in the International College of Oral Implantology, and is recognized by the American Academy of Dental Sleep Medicine with the Qualified Dentist designation. Jeff has lectured internationally on the physiologic effects of sleep, TMD, pain, and performance, and has published several articles on these topics. Some of what we'll be discussing on today's show includes how Jill and Jeff built a practice with a focus on addressing the etiology of disease, not just treating the symptoms, the role that airway-focused treatment plays in that approach, the numerous benefits of early proactive orthodontic treatment, common signs and symptoms of sleep disorders that you can see and detect in your pediatric and adult patients, the impact that oral appliance therapy can have on heart rate variability and even athletic performance, Jeff's unique approach to address TMD and airway dysfunction in adults, the future of sleep medicine, including a new pharmacological approach which has recently been released, and much, much more. As always, please share this show with others if you think they could benefit from this information. Jill and Jeff really have an amazing story of how they got to this point in their respective careers and how they are helping so many patients with their approach to patient care. In addition, if you feel the Doc Podcast has earned a 5-star review, we'd love to receive that from you on Apple or Spotify. Thanks so much, as always, for your support of the show. And without further ado, let's get on to today's episode with Jill Meyer and Jeff Hindin. Enjoy the show, everybody. Welcome to the Doc Podcast, Jill and Jeff.
Hey,
Thanks.
How are you?
Thanks for having us.
I'm doing great, thanks. Thanks so much for coming on in your busy schedules to get both of you at the same time. I really appreciate it. I know you all have a lot going on with your practices. To start off, as my audience knows, I love learning more about people's stories and their backgrounds. I know you both went to SUNY Buffalo, right, for your education. I almost went to SUNY Buffalo for dental school. I ended up at Stony Brook, but I was really, really close to the two. The day that I went out there for my interview, and I was from upstate New York, so snow didn't bother me, but I drove in the middle of a blizzard up there, and it was quite a trip that I went up there too, and really loved the school, but I just kind of thought Stony Brook might be a little better fit, but great school. So when were you guys in dental school? What year? Same time?
No, he's 2 years ahead of me.
Yeah. So
Okay.
I was there from 89 to 93.
Yeah,
Okay.
from 91 to 95.
Okay, so you guys are a few years ahead of me. I was dental school 98 to 02, so you guys are a little bit ahead of me in that department. But so tell me a little bit about your journey. How did you guys get into this? And you can take it back as far as you want, really. And in that, incorporate maybe some of how you guys met up and then decided to build the practice in the center that you now have.
Come on, start.
You want me to start?
Well, we met in dental school.
We met in dental
Surprise,
school,
right?
yeah, right.
Okay, yep.
I was in Buffalo for dental school. I did my residency at the VA hospital, which was fantastic. I learned a ton. I really liked surgery, so I spent a lot of time doing surgery. And also prosthetics was really big at the VA, so I did a lot with that. And we noticed different things because in our rotations, number one, we were intubating patients during our anesthesiology rotation. And then with the ER cases, we looked at different things. So the systemic piece of how the mouth is connected to the rest of the body really was impacted on me while we were there. From there, when I got into practice, I started doing TMD right off the bat. And then, sleep didn't come out really until like 2000 and things like that. But we were really seeing some interesting things happen with our TMD patients where they would come back and say, hey, besides my jaw, I have this, and this, feeling better. And I was like, I was always taught, or what I learned is I always ask more questions. Why is that happening? And then I started to compile these different things that we were looking at, and from there that led to how do I measure these things in my office? How can I tell objectively that people are doing better? Because, relying on subjective answers can be very, very difficult.
Now, did you start your own? Did you go in with anybody at that point, or were you starting your own, or your dad? Were you?
I went to practice with my father.
Okay.
So we were, that was back in '94. From there on, I met some of the really big guys in TMD world. And it was interesting because we would get the same results, but we would do things differently. And I was trying to look for that common thread and what that piece was. And, very early on, we talked about how changing a person's vertical protrusive, how that affects airway. And, from that, it led to me developing a system that I got FDA clearance for to look at physiologic parameters in patients. And then also I did a study on kids with Tourette's with Weill Cornell here in New York City that was published in a medical journal. And we've done other studies at Northwest. We did with physical therapists looking at how that affects. I work with some major athletes in different sports. You name the sport, I've probably been there. And it's been, I go in places doing things that you would never think that you would have seen in dentistry. But, my hypothesis has always been the same, that, the airway affects the autonomic nervous system. And the things that we do in the mouth change those things, And from that, it's been very interesting. And I've yet to disprove that hypothesis. I'm very science-based. We want to make sure that everything we're doing is based in science to support things so that it moves forward. Because as you know, in dentistry, a lot of times people go forward and make statements and they don't have anything to back it up. And I don't want that to happen for our patients, certainly. And then for the people who are doing it the right way. And then Jill and I met in dental school. And
he stayed up an extra year.
Stayed an extra year.
Residency well. And then I graduated.
Wow,
came back.
Come on.
Back down. I did my residency through Columbia Presbyterian, which also included the Montrose VA, which is in Westchester. So the VA, as Jeff had stated, you get to do a lot of prosthodontics and all different kinds of treatment in the GPR. I am a GP, but I have since focused pretty much my practice on pediatrics and orthodontics. When I first graduated, I was doing general dentistry, seeing adults, children, and Jeff kind of got me a little bit into TMD. And so we were seeing a relationship between breathing better, at least we thought when we raised the vertical, right? We increased VD. Seemed like patients were breathing better, feeling better. And then I had kids of my own, and that's often what brings, I think, a lot of us into treating kids, and in my case, airway, because my own kids suffered. My old one had chronic ear infections. I really noticed I didn't want them on antibiotics every month, come back every month. Wasn't sleeping well, waking up all the time, had to sleep in his little car seat. Now I put that together because he was more vertical. He was probably breathing better than lying flat down in a crib. So when they were about maybe 3 and 5, I was just taking more CE. I tagged along with Jeff to TMD conference, and it happened to be related to kids, pediatric. And there were a lot of orthos there, or GPs who did ortho. It was a combination. And I started seeing that expansion, and they were showing SAS before and afters, like airway seemed to be improving with certain treatments, but certain ortho, as you probably know, sometimes the airway looked worse after the extractions. I know we can't say 100% that that's scientifically proven, but we have seen sometimes that extract teeth, you push things, retract, push things back, and the airway looks smaller. So I was like, my older son, I think he looked really narrow and bald, even though I breastfed both of them for over 2 years, because I thought, they'll be fine. I'll just do that. Because you hear that on the internet, right? You hear that. The time we didn't have the internet. The time it was like my lactation consultant and other people were like, just breastfeed as long as possible and they'll be healthy. But that, unfortunately, it's multifactorial. As we said, it's not the only thing that we can do or should do for good health for children. So, my older son especially was just so narrow and balded. Like he looked like he never breastfed, even though he did.
You're still a good mom.
Yeah, I did have a lot of guilt.
And that's real. Yeah, I hear that a lot. Yeah.
Oh, he also wasn't growing. That was the other thing. He like fell off the growth chart, and the pediatricians, all they see is that, and they're like, "Oh, are you feeding him enough?" I mean, obviously there was more to it. They never even asked about sleep, how they were sleeping, and the relationship with growth hormone and sleep. So long story short, I was like, he needs expansion, and I go to the local orthodontist who we usually refer to, and they're great. I'm not knocking orthodontists, and I know you're an orthodontist. Nothing. I actually am friends with a lot of orthodontists, and we feed off each other. We learn from each other.
Yeah, which is all. That's what it should be. Yeah. Yep.
Right. But he looked at him. He was probably 5, and he said, "Oh, he's too young.
Yeah.
Come back."
Yeah.
And I don't know. It was just a gut feeling. I'm like, I want to help him now.
And then the thing is, obviously treating TMD and sleep in my part of the practice, I was like, I don't get to take care of the people early, so I have to take care of them when they have the problem. I didn't want my son to have that problem.
Yes.
And so it was like, what do we do from here? But this is going back, 20 something years.
This was like 2005.
And we're like, what do we do about it?
Not that many people were talking about airway then, or probably only.
No.
We were looking
at very few.
About sleep. And
sleep and TMD.
And what was the relationship with those things? There were very few of us who were talking about it, but then, and I don't mean to interrupt.
No, it's okay. So I guess to make a long story short, since I couldn't find an orthodontist who wanted to treat him at age 5, I just decided I started taking CE, learning ortho on my own, and I learned through various people. IO is one of the big ones, International Association of Orthodontists, where I learned ortho. And I just thought, I'll just expand him. And then, of course, you can't stop there and I'm like, oh my God, now what do? I don't know how to do brackets and wires. How do I fix this? How do I improve his occlusion, all that? So that kind of opened up that whole, I guess, can of worms for me, because I was like, wow, now I have to take more and more. And I just kept learning more and more. Then before I know it, I'm like, all right, now I see all these children in my practice who are the same issues. I have to help them. I can't just treat my own kids. So then more CE. And kind of morphed into, I never really thought I was going to do orthodontics, and now morphed into, I just had so many patients that I was doing orthodontics on, and really early treatment, I have to say. The local orthodontists didn't even want this. I wasn't even competing with them. They didn't want these cases.
Right. Most don't. Yeah.
Yeah. And so here I am now. I just focus on early treatment, pediatrics, and ortho. I mean, I'll do a phase 2. I'll do brackets and wires. I'll do major ortho, and I'll do adults here and there.
You finish the cases with the TMD.
Right. Right. But we're always looking at the joints, TMJ, and we're always looking at airway, not just straightening teeth. Like, that's what I tell all the parents. It's not about the teeth. Like, that's the last thing we're going to look at and care about is like the teeth.
Which is crazy when your dentist tells you that, because it's like, you're like, you understand you're a dentist. I'm like, no, I understand that. It's because I teach at Pitt. I teach the continuum and sleep-related breathing disorders. And so we're teaching dentists about TMD sleep and how to do exams the right way. And I start the course off and I ask, how many dentists are in the room? And, everybody raises their hand. I said, how many doctors? And everybody just sits there looking around. And I'm like, it's frustrating because you learned all these physiologic things, but yet we don't apply them. And you see every day how those things apply in our practice, because we can certainly make people better, but we can make them worse too. And that's the scary part, I think.
Yeah. Or we can not change them at all for the better. Right?
And that's better than doing something sometimes. So, I mean, look at those things.
Yeah. No, thank you for sharing the history of that. It's really cool. I love the context in the story because people know who you are today. Many people know of you both and your dad, and you have really a significant name in the dental arena. And they don't realize that you guys started back in dental school like the rest of us, right? Went on your journey. It's not like you came out knowing a ton about this. And Jeff, you got some great training, it sounds like, at the VA in your residency. And Jill, then I hear that all the time with the impetus behind this being family, kids, right? And oftentimes with moms of kids. And they're like, wait, something's not right with my child. Moms just know. They just know. And anybody who's done this in practice, I just last night had a call with a colleague, and he literally said to me that he had a patient that day who the mom said, I knew something was wrong with him, and I can't believe it was the orthodontist who figured it out, right? Turns out the kid has chronic allergic rhinitis and nasal passageway obstruction. He can't breathe through his nose, and he can't sleep. And so we'll get into some more of the details of that a little bit, but just to kind of underscore that point that it's a journey for all of us. And I really hope my orthodontic colleagues, and one of the cool parts about this show, it's really what I wanted to create, is it's not just for orthodontists, for general dentists, for pediatric dentists, for dentists. I have physicians that listen. I have a lot of lay people that listen to the show. And because I, yes, am an orthodontist, I have that in my background. I also practiced for 2 decades. I understand what it's like to run a practice, and I understand the need, and Jeff, you alluded to this, but continue to ask why and ask questions. And Jill, you indirectly were saying it with your son. Like, why is he like this? What is going on? This isn't okay. And sadly, many orthodontic colleagues, and this isn't a disparaging comment, it's the truth. And you said this as well, Jill, they see a 5-year-old and they say it's too young. We don't treat that young. And that's not based on any evidence. That's not based on any hard data. There are no randomized controlled trials showing what age you start orthodontic treatment at. It's just become convention. And so, and the studies that do look at it, and this is what I want to get your thoughts on more as we talk about the scientific side of what you're doing. The studies that do look at when we start care, just look at the teeth, which you both said, that's the last part, right? So we're judging whether or not we start treatment as, oh, can I fix and straighten this kiddo's teeth if I wait until they're an adolescent versus starting at 5 or 6 or 4 or 7, whatever it is. And I say all the time, that's not the question we should be asking. We have to get away from this phase 1, phase none, phase 2 debate, this extraction, non-extraction debate, and look at it as we have to focus on treating our patients. And I love what you said, Jeff, about asking the room of dentists, how many are doctors? It's like we almost forget that, right? I mean, we go through tremendous training. It is very rigorous in the didactics. I mean, at Stony Brook, I think Buffalo too, and the New York State schools, we were in with the med students the first 2 years.
Absolutely.
Right? I mean, we were in with them in these courses first 2 years. And then on top of that, they were
courses.
Right. They were doing like shadowing on rounds and stuff, and we're going and then learning all the dentistry on top of the medical curriculum. I remember many of my colleagues that were in medical school were like, gosh, you guys have it worse than us. Like, we get to go study. You guys got to go back to the dental school and go to labs and making dentures. And so, and learning restorative and et cetera. So it's so many great points that you both brought up there. So on that, the science side, the being science-based, the being evidence-based. Whole lecture I give, and I tied into many of the lectures I give, talks about evidence basis and what it is. And just to briefly summarize, when Sackett developed the concept of evidence basis throughout, kind of started in the 70s into the 80s, and then was formalized in 91 by Gordon Guyat, who named it, who was a student of Sackett's, what he called the triangular epistemology. It was a philosophy of 3 main things. And those 3 things are, yes, the data in the research are one of those. The other is the patient values and preferences, and the other is the clinical judgment and experience.
Right.
And everything you both just said incorporated all 3 of those things. Mm-hmm. That is evidence basis. What have you found being front facing and really known in the community and being huge advocates for treating patients a little differently? What have you found that you face in terms of resistance from people who think what you're doing isn't evidence-based, or there's no reason to be doing some of the things you're doing? And I guess we can start with Jill on that and the earlier kids, and then go to Jeff and some of the things that you've learned and been doing in the TMD arena in the adult patients.
I definitely face that. I mean, we have, as you know, we have articles to support our side. Mm-hmm. And I say, listen, I'm treating patients, I'm treating people, and when parents are coming back and they're saying their child's sleeping better, how can I argue with that? Or they're breathing better, or they're focusing better in school, getting better grades.
But you have the objective things like this. You get the referrals from sleep physicians for
that too. Thank you for reminding me. I do work with a pediatric sleep physician,
and
I have sleep studies.
You don't treat anybody who doesn't have a diagnosis. They have a diagnosis, so they come in, all right, from a board certified sleep physician and says they have obstructive sleep apnea. You do the treatment. that's been the doctor has asked you to do. You do the treatment, and they go back for a second sleep study, and they don't have sleep apnea. I mean, what's the argument going to be?
Yeah, I have many cases like that. I also, for the most part, I only start very young if we have a diagnosis of sleep apnea or I see crossbite. I try not to just be too general because I know out there's someone like they go back to their general dentist and they might criticize me or say something. So I try to have a really good record of why I'm starting at this age.
And there's so many clinical signs, that we have with the crossbites, with the high voltage palate, the continued ear infections and all those things. I mean, one of the earlier things that, you had was like with the kids with the tonsil, the hypertrophic tonsils, and class 4 tonsils, and pediatrician is telling the mom that the kid's going to grow out of it.
Yeah. Hear that.
I'm like, and it's a main part of the child's life where they're going to be, brain function, all these other things performing. What's suffering in that time? And
which doesn't get talked about even close to enough. The comorbidities they're suffering from while they're waiting, whether they grow out of it or not, I agree with you. It's almost a separate debate.
And it's and it was frustrating. So we I called that pediatrician. I said, hey, thank you for seeing.
I gave him a book.
And gave him a book. And
what book was it? What book do you recommend for that?
The Long Face, Vertical Dimension, the Swedish, I'm forgetting the name, but it's about the Swedish researchers. Okay. It's really all about how long faces are created from not breathing well and tonsillar hypertrophy and adenoid.
Jill reads absolutely everything.
No, you read that.
Stuff. No, but
I don't think the pediatrician read that book.
She makes me look smart. So that's it. But then I called him and I said, hey, I appreciate seeing the patient. Can you write me a letter that the kid doesn't have sleep apnea?
Yeah.
And he said,
"That's always good to think of these things."
That's such a good angle. Yeah, I love it.
And he said, "Well, I can't do that." And I said, "Well, essentially, you did by saying this." I said, "So if you could just have it," I said, "I just need it for my records. I want to put in my records that you said that he doesn't have sleep apnea." And he's like, "Well, and we went back and forth a few times." And he finally sent the letter so that the kid could get the referral, and he got the tonsillectomy and adenoidectomy. And oh my God, the kid's doing so much better. And then you look at the the papers that are out there by Gozal, where he basically took thousands of kids and looked at their school performance, treat them, and then how they get better. What's the argument when you have, we're not talking about, you want to talk about evidence-based and you talk about, some of the orthodontic literature where the N is 10 or 15 as opposed to, what's the discussion? And so I try to kind of put the onus back onto, just think about what we're talking about with those things. I mean,
thank you. You articulated better than I could.
I completely agree with that. And actually, David will be on the show. His episode will be released at a similar time to yours, within probably a few weeks of one another. And that one study he had in 2016, American Journal of Respiratory Critical Care Medicine, he looked at 1,010 patients, 1,010 patients, and found that snoring alone, literally has the same impact and significant impact on neurocognitive development as severe airway obstruction. So it's not even, the fact too that.
And importantly, in that he also talked about, one of the major pieces or the effect of when you do a TNA was age, was the most limiting factor. That it had to be before age 7 or there would be a relapse. Which means you got to get in there early and do things.
And so I think a lot of the relapse is because they structurally, I say all the time, and Jay, you said this is multifactorial, and kind of my catchphrase I always say is the etiology is multifactorial. The solution has to be multifaceted and often multidisciplinary. And you get these heterogeneous conditions that are hard to, and I think that gets to why a lot of people don't want to do it. It's kind of hard to diagnose. You have to spend, you both alluded to this, more time in your diagnostics. You can't just be like quick, like, hey, we're going to straighten your teeth. Or, I so appreciate what you said, Jill, of like, you're not just going to throw the same thing at every patient because that's what you do. That takes more time though. That takes a lot more work. So go ahead.
But you're trained for it, right? And I think the other piece is that if you're doing things where your exam takes longer, you're looking at all these different pieces, you never tell a patient that they have a problem, right? Patient comes to you with a chief complaint and we have to figure out what's going on. And it's like, a patient comes in with an obvious sleep problem, but they're just coming in for general dentistry and things like that, you don't say, oh, hey, you have sleep apnea, because number one, you don't know, and number two, and so I'm doing the exam. I'm seeing the wear facets on their teeth, the scallop tongue, maybe the high vaulted palatal, the narrow arches, the closed off airway, different things. You ask them if they snore. If it's men, they're usually, like, my wife says I do. And I joke around and I'm like, yeah, well, it's her problem, not yours, right? And going forward, it's like really what our job is as dentists, or we'll say doctors, is to inform our patients of the information that we find and what the options that they have in order to treat. And I think, we've gotten away from it into, real quick, oh, you need this, this, and this, and that's what's accepted, as opposed to how do we make the patient think about making their health better? I mean, treating sleep isn't just, I'm going to give you a sleep appliance or a CPAP and you're on your way. The patient needs to lose weight. They need to do exercise. They need to change their sleep habits. And so it really is a 90-10 relationship where they need to do 90% of the work, and get those things. You have to get them involved. I mean, you're talking about the hard road. I mean, with Jill, she's treating these kids early. They got to make sure that they wear the appliances, keep things in. People want to get thin quickly. So what do?
People want you to do something to them, but they have to be actively involved in my treatment. Well, your treatment too.
It's like you look at weight loss, right? I could change my diet and do things, or I could take a GLP-1.
Right.
So what's the choice? But the resistance I've seen, because when I lecture, because to jump on your stuff, is that when I went out to lecture and I started lecturing about looking at the physiology of patients, and I had basically the work that I was doing where, I had that system and I was looking at EKGs, I was looking at EMGs, I was looking at heart rate variability and different analysis of those things. And now I go to anesthesia groups and I'm lecturing as a dentist to those groups. I'm going to, pain meetings and things like that and talking about the things. I got the most resistance at the dental meetings. Whereas the medical thing, I would go to lecture and I would be at a pain meeting and the doctor's like, oh, you're gonna talk about how you put those appliances in, and people walk around and blah blah blah. And I was like, terrific, and then I'd get up and I'd show how, look what happened to their physiology when I put their appliance in, like their heart rate dropped, their respiration dropped, their heart rate variability increased, which are all good things. And the doctor comes up after and says, I get it, I see what's going on now. And so I was looking for that common language to have that. But in dentistry, it's like, I think part of what happens is that we have beliefs and we don't want to show that or feel that we're doing something wrong, right? Because you went through dental school. They always made you feel like such a good person most of the time when you were there.
Oh, yeah. It's very, very fulfilling experience.
Why is it the personality of people that go there are perfectionists and we have to have that, and somebody comes and fix something in your house and you're like, well, it's off by a millimeter. And they're like, what are you talking about? I'm like, you don't understand. When the door, it's making a squeak. And they're like,
right.
Why do you look at it like that? Like, well, because I have to, right? And so it's that thing of what are we doing? And if you think about how effective medications have to be for somebody to be okay, or how effective medical treatment has to be, if they get 75%, it's a home run.
That's huge.
Right?
Yeah, huge.
And for us, if it's below 99, it's a failure.
Right. Such a great point, Jeff. Yeah.
And it's it's hard. And you think about like the things that we're treating, like, if you do a restoration, if you do ortho and you follow the Ceph analysis and you do everything and you get everything exactly where it should be and you got cuspal rise and blah, 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 all the other stuff. Terrific.
Perfect.
But
the patient isn't healthy.
But I don't feel good. Yeah, right. Your teeth are in the right place and you look good. And look at the models. You see how your models line up? Yeah, well, your models don't breathe, right? So,
yeah, and that's such a great point. And that's why I feel the orthodontists are struggling with this. Everything you just said, the perfectionism, I didn't learn this. That's a huge one I hear. If this was a thing, we would have learned about it in school. Well, I've taught at multiple orthodontic residencies, and I can tell you they are decades behind private practice. I shouldn't say that as a generalization. There are some that are not that way, but many of them are. They're not even incorporating routine CBCT. They're fighting that. They're fighting it. And I try to remind them that they fought cephalometrics the first 15 to 20 years it was in existence in the mid 1900s. And they're not teaching it. A lot of teaching I do with residents around the country is teaching how to read these CBCTs and understand them and not to be scared of them.
It's true because orthodontists, are in the best situation to help people going forward.
Yes.
I mean, it's like I'm jealous because you have it right in the palm of your hand to do things. And I think
prevent
problems. I never have to see these patients again. I mean, I don't have to treat TMD or sleep. And I think that to me, that should be the message that orthodontists look at. I mean, that they have what it takes and what to do to make people not have the problems going forward. That's exciting.
And it's very gratifying.
I agree.
I mean, when patients come back happy that they're feeling better and they hug and kiss you,
Right.
Yeah, sure.
You feel that way more about than straight teeth. They're like, I'm feeling better. I'm sleeping better.
I say all the time, I straightened a lot of teeth, and I pride myself in being a very good tooth straightener. I went to UConn. I was trained by Charlie Burstone and Ravi Nanda. Like I know how to straighten teeth, and I'm proud to be very good at it. It's rewarding. I'm not saying it's not. I love that part. It doesn't even compare. It pales in comparison to when you detect the issues of a sleep-related breathing disorder in a child, and you uncover that and help guide the parents through what's going on, get them to the right medical providers as needed, and then provide the appropriate dental orthodontic treatment as needed. Again, I'm not saying expansion cures every airway problem. I'm not saying that you have a set formula. That's part of the challenge, is you have to really dig into the diagnostics. And Jeff Rouse, who I know you guys know as well, he talked on my show about normalizing anatomy. And that's the key, right? We want to normalize that anatomy. When you do all that, and you have these parents in tears hugging you. I mean, I've seen like burly, like blue collar dads, barely don't say much and don't even come to a lot of appointments, in tears in my office. Like, you saved my boy. Everyone was telling me my boy was stupid. I knew he wasn't stupid.
Yeah.
Since you started treating him, he's now at grade level. He was like 2 levels below or whatever it was. I mean, I've had multiple of these as you have. It's so rewarding. It's so fulfilling. And at the end of the day, we all went into this to help patients, to make people's lives better. And I really think that my orthodontic colleagues who disagree with a lot of what we're saying, the problem is they've really been co-opted by the system. And I don't think it's nefarious. I don't think they have ill will. I don't think they looking at it like, I don't want to help these people. They've just gone all in. Yeah. They've based their entire existence, their careers, their community reputation, their reputation with their team on saying that what we're talking about isn't a thing. And it's really, really hard. And maybe they've treated their own family members that way, right? Maybe they didn't recognize these issues in their kids. And on the extraction thing, and then I want to ask another question about the direction of care and the perspective over a long period of time. But on the extraction thing, I always say too, it's not like someone walks into the dental or oral surgeon office in the morning and is a beautiful sleeper with no sleep disordered breathing at all, and then gets 4 premolars extracted and goes home that night and has obstructive sleep apnea. Like, it's not extracting the teeth that is causing the problem. Many of those patients had the problem before.
Airway problem already.
Right? And the teeth are
That's why they have crowding.
That's exactly why they have the crowding. So, we get in this argument, and the orthodontists are so tied to like extractions don't hurt. I'm like, we have to stop talking like that. It's looking at our patients holistically. So what are some of the biggest obstacles you guys have faced and challenges? It doesn't necessarily even have to be from others in the community, just in general. As you started on this journey and as you were starting to do these things, we can start with Jill in the pediatrics and then go to Jeff and the adults. As you were expanding your knowledge in sleep and airway, and as Jeff said, 20 years ago, this wasn't even a discussion really in the dental profession. So what have been some of the challenges? And the reason I'm asking that is a lot of young docs listen to the show and they really think in line with the way we're speaking, but they just don't know how to do it. So kind of what was your journey? And in that, what would be some advice you could give to others?
Well, I kind of don't care what other people think.
and that's important. I'm with you. You got to have thick skin to do this.
Yeah, that. And honestly, the feedback from my patients is huge. Like people are looking to come to me. Yes. And they're finding me and they have it. They're already pretty well, they have the knowledge because they're seeing things in their children. They're already suspicious. And then unfortunately or fortunately nowadays, they're going on the internet and they're finding a lot of this information and they're tying things together. And so I guess I'm lucky in the respect that nowadays I'm getting a lot of patients who are coming from pediatric sleep physicians because they're referring to me, or they already are diagnosed with a sleep disorder, and then they know now they have to come and get some ortho treatment.
Did that take a while? Or was that like, was it like kind of a sudden thing, or was it years?
It took a while, but just going to different conferences and meeting different people who are like-minded. We'll look out in the community, like you need an ENT who is like-minded. So we'll try to find someone. We'll go to their office and maybe talk to them, show them what we're finding, show them our CBCTs, different things, and have a discussion. You find out who has similar treatment philosophies and who doesn't. And then the people I work with, obviously, we're like-minded. And so I'm getting referrals from ENTs. I get a lot of referrals from SLPs, myofunctional therapists. So I have to say, I'm sure a long time ago, it was probably more difficult, but now I really feel like a lot of my patients are coming to me knowing that they have an issue and knowing that they need my treatment. And I don't have to find them in my practice and bring it up to them. I know I'm trying to think like back then.
Yeah, but
what
you're
were we
also
doing?
talking like how you got to this point. I mean, because you would talk to different practitioners that you knew who were doing things and that, and then AAPNB was basically when we started that. It was because there were a bunch of like-minded parties. I'm like, we're seeing this. Let's get together and discuss these ideas. But
I think my CE journey. Well, I'm just trying to think my CE journey. Like I kind of also would pick out certain courses that talked more about ortho and airway, and so then I'd meet other colleagues, whether they're general dentists, orthos, and we would discuss things, and we had that camaraderie. So I felt like I had support. The IAO also, I feel like I have support. Actually, everyone in the IAO really has different philosophies, but for the most part, everyone I'm in the New England chapter, so I should preface that. I do belong to the IAO national or international, but we have a New England chapter. And so I go there 3 times a year. I actually teach there as well. In there, we have a little residency program where we're teaching GPs ortho. And, we bring in guest speakers, some are orthodontists and some are GPs, some are TMD specialists. And so I feel like I'm kind of in that group and we all support each other, and everyone has a little different philosophy. Most people are looking at airway, but not everyone. We actually just had someone speak at the IO who said, I don't look at airway. Granted, we're all kind of like not happy about that, but like, all right, I'll take from him what I can. And we try to explain our point of view. And so he was open to it. I don't know if he's going to go practice like that, but I don't know, maybe over the years I'm finding I'm getting more support and at least people respecting the different philosophies.
Yeah, I think it definitely gets easier, as you said, once you start to see it. It's kind of like anything, once you put the work in, and it's always going to be harder initially. And then once you start to do it more and get better at it, and they get I love the part you said about the feedback from the patients and the parents. I mean, that just, and that's why I'm on this mission. Literally, that is my why. That's why I transitioned away from my practice to go teach this on the scale I'm teaching it now and raise awareness, because I was so frustrated by how many parents were saying to me, why are you the only one doing this? And I was north of you guys. Yeah, where we weren't sharing. I was probably about an hour and a half at least north of you guys. So we weren't even in the same communities at all. And in my community up outside of Albany, I mean, literally, they're like, we took our other child to another orthodontist, or, this patient, we got another opinion from another 2 people. They didn't even mention anything about breathing or airway. Now you're telling me that that's the cause of a lot of this, and you're sending me to the ENT and the allergist or whatever else. Like, why are you so different? And I would always say, because we're not learning this. I've gone on a bit of a different journey. I've had to take a lot of other courses and look into things differently, be very critical of myself. And it does take a lot of resilience and self-reflection, because when you start on this, and I also love, you said, get a community around you of people that even if they're not like-minded, they're open-minded. Yeah. And you can have this open exchange of ideas where you can do this together. And I love that. So Jeff, in your journey in TMD, and I know that has a longer history of being something in our profession, but clearly as you started incorporating more sleep, you've seen a lot in your almost 3 decades here of practice. What does that look like on your journey? And what would be some of your advice to people who are trying to get involved in that arena, but maybe intimidated by it or just aware of it.
Yeah. Well, I mean, look, you got to look at the pressure, right? You get out of dental school now, and how much do you owe? In right, it's huge. In our time, we owed a lot, but the money now it's gotten crazy. So, it's got to be hard for dentists to say, okay, I'm going to incorporate a new modality into my practice that a lot of people might not be into and things like that. And so, that process, it takes time and it have to be slow. And I think you have to build up the confidence. I mean, I think certainly once you see something, you can't unsee it, right? So, agreed. And we also don't know what we don't know. So there's sometimes people feel better with that. In the TMD world, there are the group now that is basically looks at how we treat TMD. Some of the primary things are it's going to be a psychosocial problem or you treat it with medications, right? And certainly there's a psychosocial piece to it, but I'm not using medications in my practice. I never had, I never will. And I get good results and I don't sit there and do things. But, when you're in dental school, the other thing is if you change somebody's bite, I mean, it was one of the top criminal offenses right below murder, I think, And so there's that fear of what do you do? And certainly with TMD, was the bite right in the right place at that time anyway. Then you get into sleep, which we know there's just a ton of literature out there of how effective it is and what things do. But you don't want to do it where, you take a course from a manufacturer that says, okay, here's 2 days and you take impressions and you put the appliance in and you're all set. Well, a lot of other things that go on with that. What's the pharmacology of what's going on? What's the different anatomical issues? Have you looked at TMD? And I mean, the crossover between TMD and sleep, the literature says 75. I'd say it's probably closer to 88%, something like that.
And talk a little bit more about that if you would. Sorry to interrupt you on that, but I want to hit on that with you have a lot of knowledge and expertise in that area. That to us, the three of us sitting here, we hear that and we're like, yeah, sure. There are a lot of people listening who might be like, no way. That's almost 9 out of 10 patients have that. Talk a little bit more about that interrelationship between the two.
Sure. So, I mean, if you think about it, right, and I'm going to get even worse because we're going to talk about physiology and things like that. But when you think about what our body needs to do, right, our brain is stupid. All he wants to do is keep us alive. We need to breathe. And so if our airway closes, we're laying on our back now, our tongue or our genioglossus muscle is basically our main respiratory dilator muscle, closes our airway off. We're going to struggle in order to breathe. If our teeth are in the way, we're going to blow through our teeth. If our joint is in the way, our condylar heads we're going to destroy them in order to get those things forward. So now you have a patient that comes in, they may have an issue where the discs are, they have a little clicker pop. And what's that mean? That means that the disc is either partially out of place or partially, or dislocated. And when we open, click, it goes back into place, right? But now you go to treat somebody with a sleep appliance. And what happens now? Well, now we're moving the condylar heads forward a little bit and we're changing the position of the condyles. And now my bite is off. Well, is it that your bite is off or that now we actually have a better position between the condylar heads and the disc, and now that's where your bite really should be. So I think, you talk about teeth straightening and things like that. If we don't respect the joint, all that stuff's going to fall apart. Why do we have these bars from canine to canine on upper and lower teeth? And then you wear clear aligners on top of that to make sure that everything, well, why, the question is, why? Why is that stuff going to move? And the body physiology, we need to breathe. We're going to change things in our body. And the genioglossus muscle is one of the strongest muscles that we have in our body. And it's going to move those teeth. And so you can't just look at sleep and say, oh, yeah, we'll make an appliance and throw it in your mouth. You got to look at what's going on in the joint. I mean, it's just, and people have those problems because they have problems breathing.
Yeah. And so do you find when you're approaching it, and you have a patient come in with a temporal mandibular disorder or a concern, or you detect one, maybe they don't even have it, but you detect something in your diagnostics, you're instantly you're going to evaluate sleep as well. Is that correct?
Yeah, because I'm going to look at everything. I mean, my exam is at least an hour, if not more, and I'm looking at everything. But I'm also a big part is I'm having a discussion with patients about what their history is, what medications they are, and what medical issues they have. We have CBCTs now, which we didn't have when I started in practice. And oh my God, the wealth of knowledge that you get from that. I don't know why you would want to not use it.
Agreed.
I mean, it's incredible because now we can visualize the joints. I mean, and I'm going back to when we were taking tomograms, and if I would get MRIs if I could. Now I've been doing it for a number of years. And I get MRI on every TMJ patient I treat. I will not treat without it. But yeah, you see these similar things in our patients, right, over and over and over again. And I was teaching in Pitt last week with my friend John Tucker, and one of the dentists, every one of them has to be treated as a patient, so that they go through the process.
It's fascinating that.
Interesting, cool.
I'll have this problem.
And so they come in, and I'm looking at the dentist models, and I look at it, and I know what the problem is right away, And so I show it to John, and he just laughs because it's like, and if I showed it to you, you'd be like, I know what it is, And she's had an extraction case and high vaulted palate. And she's sitting right in front of me while I'm lecturing. And I'm sitting there the whole time. And I said to her, how long have you had your migraine headaches for? And she says, yeah, I've had them for like 20 years. How did you know I had them? Right. And it's so you start to see those patterns, right? And I get things, and it's like, for me, the dental visit is more dental CSI than anything else. And I don't look at these things as being problems. I look at things as being a compensation. I gave a lecture last night, and I'm showing this case of a patient who bruxes, and she has 7 millimeters of overjet. Yet when she protrudes, her teeth fit perfectly together.
Perfectly. Yes. All the time. See that? Yes.
But that's almost a full centimeter forward that she is going. And in a parafunction, obviously, it could be during the day, but at night, why is she doing that? Right.
Yes.
And then we hook her up to her physiology, and guess what happens? When she gets into that position, her EMGs drop off. So she has no muscle pain. She has all these other things. And then when we look at the CBC, or condylar heads, one is destroyed. I mean, it's like almost gone. And guess what? When she slides forward, that was the one that was in the way first. So, it's just form, follow, and function of what's happening and that thing to survive. So, like, when I look at the physiology.
Do you want to explain the physiology? Do you want him to explain?
Yeah, sure. Go into it. Absolutely. Yeah.
I think it's very interesting.
So we're looking at what happens with people's heart rate and respiration rate. Heart rate is one thing. Heart rate is basically looking at a measurement over a period of time. So, 55, 56, 54, 55, and then you take an average of that over 5 seconds. Heart rate variability actually looks at what happens between each successive beat. So you're actually measuring that small time in milliseconds that occurs between each beat. In a healthy individual, that should be a variation in that piece. So I tell people it's like a rubber band. I got a rubber band that's 10 centimeters. I stretch it to 12, to 15, to 17, and now I go to 22. The rubber band is okay because I've built elasticity into the system, which is how our bodies work. In the same thing, if I take that rubber band and I cycle it 12, 12, 12, 12, 12, 12, 12, and now go to 22, the rubber band breaks. And heart rate variability is really interesting because you take, one thing in particular, it is 96% predictive of it as an independent risk factor for death after a first MI. So if you have had a heart attack and you have low heart rate variability and you have a low HRV, your chances of surviving 3 years are 4%. And so I started to look at these things because I was in my office and I'm like,
these are things cardiologists use. The military.
Peter Attia, I love talking about Outlive in that book, and he talks a ton about this, and it's gotten in kind of, people view it as like biohacking with HRT because there are things you can do to impact it. But I love that you're going into the physiology of it because people don't realize that as part of that autonomic nervous system that you were referencing earlier, that is all controlled and has a direct impact on everything downstream.
Right, exactly.
And vice versa. And everything downstream is then cycling back with feedback to affect the physiology. And that, so please go ahead.
And the thing is, so when I start lecturing about HRV, this is like 2004, 2005, and I'm going to dental conferences and they're like, what is this? Because there was really.
You were talking about it even back then?
Back then, yeah. I mean, that's when I started building my system.
Right. That's amazing, Jeff.
And so you sit there and you're like, what's going on? But, meanwhile.
Tell about your uncle's story. I'm not interrupting. Your uncle's story? Uncle Bobby. He's in the hospital.
Oh, yeah. So, I mean, how I
this is just very interesting.
How I got into it was basically I had a relative who's in the hospital in critical care. So they're hooked up to all the monitors and they're like, hey, I left my appliance at home. Can you pick it up and bring it in? So I said, sure. So I put it in and everything starts to change on the monitors. And I'm like, whoa,
no way.
That was pretty cool. And so the nurses come in and like, give me the appliance back, and everything gets normalized. And, being an inquisitive person and trying to use a scientific mind, I'm like, well, let's do it again. So I put it in and I see the things change.
Like for the better.
For the better. And then, I take it out. And so I'm doing it. I did it like 20 times till the nurses are like, what the, are you doing? And I said, this is amazing. How do I have to figure out how to measure this in the office. So I went through stuff where I got almost like a degree in electrical engineering, but I started doing stuff with cabinet graphs. I was looking at plethysma graphs. I was looking at things. And then one of my physician friends was like, you should look at heart rate variability. I'm like, well, what's heart rate variability? And then you start reading about it, and this is, again, going back 20 something years. There's quite a bit of literature where, they were doing things, but they were using something called heart rate variability biofeedback training. So breathing exercises, because the way we can affect our autonomic nervous system in a voluntary way is with breathing, right? So when we breathe in, we increase our heart rate. And when we breathe out, we decrease our heart rate. So you breathe in for 4 seconds and out for 6 seconds. We're going to decrease our heart rate. And when we do that, we decrease sympathetic activity, which increases heart rate variability. And sympathetic is our fight or flight response. I was like, wow, that's pretty amazing. And what happened was I compiled all this data, and I went to like a really, really prominent researcher in heart rate variability who was down in New Jersey. And he said, well, I can give you 15 minutes. So I drove 2.5 hours and I got down to him and I showed him, and he's like, well, it's really interesting. You saw that change. How long did it take? I said, oh, that was 64 seconds. And he said, well, what do you mean? And he said, well, that's the only case. And I said, no, I've got like 1,000 more. And so we spent 5 hours together, needless to say. He gave me a stack of literature. He's like, you got to go meet this guy, talk to this guy, and it started for me. It was like, all right, well, look at all the stuff that we're doing. And, I've done things where I hook my patients up because it's a non-invasive thing and I can look at it. I've made a temporary crown too wide buccolingually, right? And what's the major thing in crown and bridge that people do is we don't reduce enough. When you do that and you give too much lingual, right, you're affecting tongue.
Lingual contour.
You're affecting tongue position, and all of a sudden their heart rate variability gets worse.
Wow.
Right? And my shoulder hurts or this and that, and then you trim it back and it's like, look what's happening. And I was just like fascinated, because how exciting is it that, in dentistry, we have this control on the autonomic nervous system, which now we see every day with what we're doing with sleep. But it was like, holy crap. And then, so I take that and I'm trying to manipulate people's jaws that are not in good positions. And yet in orthodontics, you guys can create that.
I know.
Like they're so moldable.
When you look at athletes, and I've treated a lot of different athletes, and I made mouth.
What are some of the things you've done for the athletes?
So I made appliances, for hockey, for football, for basketball, golf. I've made some for guys who are long drive champions. And like, if you're ever up at 2:00 in the morning and you turn on ESPN Ocho, you'll see the guys hit the ball and then they'll go to their mouth and they'll pull something out and they'll put it in their pocket.
Okay.
I recently made one for somebody who's a world champion skeet shooter, which actually got me involved in skeet shooting. I've made it for Olympic fencers, for rowers, for you name it. And what we do is it's not only protecting their teeth, but we measure their physiology and we look to increase their physiology. And the pro athletes are awesome because they're like, can you give me 1%? And I'm like, 1%? And I'm like, but you think about it.
Yeah.
For us, 1% wouldn't be much because we're not athletes like them. I mean, these guys are already amazing. Their heart rate variability is already, but if I can increase it just a little bit more, it means
that's that advantage. Yeah.
Playing, I have.
So what would you say is changing? Their airway, right?
I mean,
I was going to say, like, what do they feel, or do you hook them up and determine what's happening there?
Yeah. So what happened? They're hooked up, and what happens is that I can see that when I position their jaw, and I'll use wax or something like that. When I get them in a certain position, I'll see their respiration rate will drop, their heart rate will drop, but their heart rate variability will go up, and muscle activity will drop off. So I have surface EMGs on. The muscle activity and
so they're not compensating much to breathe.
And so what I've done is I've actually done studies where I went to a pretty well-known physical therapist and trainer down in Florida, and we had Olympic athletes to high school athletes, and we made appliances for them in one room, and he did testing on them where they did a Y balance, the FMS scale, which they used for the NFL, and he saw increases in everything when we got it right. There was one patient where I was actually off in my measurements, and that patient didn't do as well. I went back and adjusted. They redid it, and they did better in the testing. And it was everything from tech to stop, recall, where they're slapping lights and things like that. So increasing those things. But, you can actually see somebody's physiology. Now,
but as it relates to ortho, I'm going to interrupt a second.
Yeah.
You're increasing vertical dimension.
Yeah.
Always, most of the time.
Well, I am, because they're adults.
Right. Okay. No, I'm just trying to explain to you. So you're increasing vertical dimension. Sometimes, and or you're bringing their mandible forward, and so you're opening their airway, and they're breathing better, and so they don't have to compensate as much, and that's why all those. Yeah. Tell me if I'm wrong, right? All those.
Do you think it impacts tongue posture too? Do you think it has an impact on? Are they instructed to place their tongue in a certain position as well for junior access activity? They're not.
No.
Okay.
I keep it up to, I believe that people will, if we do things to compensate, that when we get the right position, your body's gonna find that position. And like, if you look at it.
But what I'm also, sorry to interrupt, what I'm trying to relate this to is that with ortho, we can do this permanently on young children because we're guiding their growth, whether it's guiding their mandible to come more forward into a better position, or increasing vertical if need be, all that. So that will stay with them for their lifetime versus not having to wear an appliance or having to wear a sleep appliance when they're older, or CPAP. And
on that note, do most of these people have malocclusions? Are they compensating, do you think, already? Or I guess the converse of that would be, is there somebody who has what we would deem to be a perfect occlusion, no TMD, normal airway? Do they still get an advantage by using that type of appliance as well? Or is it just people who are probably at a disadvantage for the fact that they're in a not ideal position?
No, often it's the people who have that nice class 1 occlusion.
Interesting. What do you think that is?
In the right.
Well, they kind of, you think about
they're compensated to the wrong position.
Exactly. And the thing is that you're going to survive. So what are the compensations? Well, you get forward head posture, right? You get rolling shoulders to bring in the secondary respiratory muscles. But how does that affect athletic performance, right? Because now if I have forward head posture, so like I'll take an NFL kick returner. I make him the appliance, and he said, "You know what, Doc? I can see the field better." And I'm like, what do you mean? He's like, I don't know. You did something to my eyes. And I was like, well, but then I took a picture of him with the appliance in and with it out. And guess what happens? His posture comes up. So he's actually looking downfield like this and looking downfield like this.
Sure.
So what do? We had a postural change because the airway is work. And number one. Number two, strength. Now you're working off long muscle rather than working, if you're bent forward, you can't lift up as much as you can when your back is straight. Mm-hmm. And so, why do injuries happen? And that, the physical therapists and trainers have talked to me about this, that they happen because they have imbalances, right? And they have imbalance because of your posture. They always tell you that if you want to get the most out of your workout, you have to have a good posture. If you can't breathe, you can't do that.
And breathing. Yeah. And they go hand in hand. Yeah.
Take anybody, have them stand up against the wall, their shoulders, their head against the wall, and have their teeth in occlusion, and see how long they can stay like that and breathe. And I'll bet you a lot of people can't. And then you say, okay, move your forward, you draw forward, teeth touch edge to edge. You can stand against the wall all day long. Well, what's going on? The same thing happened when we were doing the Tourette study. I got called in first they started sending me patients to my practice, and they're like, hey, I'm here so that you can, make my Tourette's go away. And I'm a dentist. I don't treat Tourette's. So I called them and I said, hey, thanks for the referral. I really appreciate it. I said, I don't treat Tourette's. I said, but I'll treat them if they have a jaw problem. And if the Tourette's gets better, it's not my fault. And they were like, okay. So then I went in and I showed them what was happening, or what my belief was, again, how the physiology was affected by airway, and that, I had bring in your worst performing a patient with Tourette's and things like that. I'll have them do a breathing exercise. And it was heart rate variability, biofeedback training. So they're breathing, watching the thing go up and down, and they had no tics. And sympathetic activity dropped off. And so I was like, and I can show it again and again and again and again. It's the physiology and the position, but yet, I keep it in simple terms because that's how I look at it. And that's how I explain it to my patients, because I know the scientific things that are happening, but I also think that every time I do it, maybe it's not going to work this time. And I haven't been able to show that, but it's been an interesting journey. But it also makes me think about things I did 30 years ago, and what could I have done better? And I don't want to ever go back to that. I don't want other people to go back to that, but discussion. That's why, like Jill's cases that she does, I'm blown away every day when I see her stuff. I mean, it's just amazing. And these kids are they're so much better after she treats them.
And what are some of those? I was actually led perfectly into what I was just going to say after that was, what are some of the things that can be done young to try to set patients up better?
Yeah. So I'm doing a lot of arch development. So upper, and I do lower expansion. And that's big. That's right. That's controversial, I guess. But
which can I have to interrupt. I'm sorry. Thank you for saying that. I talk about this all the time, and I break it down into patient A and patient B. And I'm just going to say this, and you can feel free to use this with any orthodontic colleagues. You have patient A walks in the room, okay, has a narrow maxilla and has a mandibular arch that is broad, perfectly upright, no steep curve of Wilson, molars right over the mandibular bone over the body of the mandible, so that forces are directed vertically along the long axis. Great. Bilateral posterior crossbite. Now we take patient B, same exact maxilla, right? Identical. They, instead of having nice upright lower molars, have rolled in, caved in lower molars. Okay, so they don't have a posterior crossbite. They have a steep curve of Wilson. They have, in patient A, most likely there's upper crowding, usually, because when there's a transverse deficiency, usually the teeth are crowded. So patient A didn't have crowding in the lower because their lower arch was broad and beautiful. Patient B has crowding in the lower. No one, and I ask orthodontists when I lecture to them this question, has ever been able to answer to me the scientific rationale behind why we would expand patient A and not expand the upper and the lower in patient B, because orthodontists will expand the maxilla of patient A all day long.
Right.
At 6 years old, they won't even debate it. Some even go in younger than that. Some will put quad helix or something in on a 4 or 5 year old to get rid of that posterior crossbite, especially if there's a functional shift. Yet you take patient B and we extract teeth and say there's no place to expand that. Literally, patient B has a more severe malocclusion. And the American Board of Orthodontists, I am board certified, if you take a patient with greater than 1 millimeter difference between the buccal and lingual cusps in the curve of Wilson, it's a huge number of points you start to get off on the ABO scoring criteria. So the ABO is telling us the teeth should be straight up over bone, yet we're just leaving them narrow because why? So again, feel free to use that, but I've never had anybody be able to answer me why we treat the maxilla in patient A, but don't treat either arch in patient B.
Yeah. So I'm doing upper and lower expansion, and, I'm very aware that we're not getting a true expansion in the lower, but like you said, we're uprighting the teeth. Right. Sometimes I'll bring the mandible forward if need be, if their mandible is protruded. That really does help open the airway. That's like what a sleep appliance does. Yeah, I mean, that's basically, sometimes I'll use reverse pull face mask if they have maxillary deficiency. I mean, most everyone has maxillary deficiency, but if that's a whole different story. But I'll do a lot of reverse pull face mask, especially in really young kids. It works.
And your class
great.
Right.
Right. They have the anterior cross bites, and so that's what I'm doing. And
Jill's got cases where the kids, the whole maxilla is inside the mandible. And
I'm sure you had that too. But I've also seen, unfortunately, I'm sure you've seen this too, that they're coming from other orthos or dentists and they're saying, wait on the treatment. They'll have an anterior crossbite, narrow maxilla, and they're like, wait. And I'm like, we're waiting for orthodontic surgery. That's what we're waiting for.
Yeah.
Why wait? I'm getting such great results. Yeah.
Exactly. And we go in as adults, and Jeff gets to see the effects of this. And I think that's really interesting that you have that duality to your practice where you can see both sides of it. And I've often said that most of the orthodontists who think more progressively about this, more holistically about this, myself included, had spent some time in general dentistry because we got to see those patients that were totally broken down. We got to see these cases, these 40-year-old patients oftentimes were females on psychotropic meds and going through a divorce and broken down dentition. They had ortho and they have constricted arch form, whether or not they had extractions, but they have constricted arch forms. They were left deep, little class 2-ish, right? Went through traditional orthodontics, and I'm here doing restorative treatment on them, and they're just some simple anterior bonding or aesthetic work, and they're falling asleep like on a Saturday afternoon at 1 o'clock. They're in my chair, and this was when I was a resident at UConn, and I was doing some moonlighting in my family's dental practice in upstate New York, and then I'm going back to UConn, and I'm doing the treatment. And I never, at that point, I didn't make the connection. But when I got into practice, I started thinking about it going, wait a minute, I wonder if I could do something differently when they're younger so they don't end up with these broken down dentitions and bruxing. And I want to come back to Jeff in a second with the bruxing side and how that ties into it all. So you're basically saying, Jill, just to summarize, make sure I'm understanding, and I do agree with this completely. If you go in young, when they're pliable, or as my friend Marianne Evans says, they're juicy, right? They're really juicy. They're just easy to move around. Yeah. You can do a lot of the things young that require very invasive and, if not surgical interventions, when they're older. And these are the same invasive and surgical interventions that almost every orthodontist would agree do help treat patients with sleep apnea, meaning right, maximum mandibular advancement, SARPI or MARPI or whatever you're going to do for a transverse. We're just doing that at a much younger age. And then why is that controversial? And that's not I'm that hypothetical. I'm serious.
That's what I wonder. I don't know. And I have cases because I do see kids all the way into adulthood, and then often they'll stay in the practice, and it has not.
How do they look long term?
Hundreds that they are not relapsing
without wires in the teeth.
Yeah, without wires. And
do you do any retention, just S6 retainers, or just nighttime?
Yeah, either S6? That, or I'll use like a different style of Holly. Like I like to have good tongue, allow for good tongue posture, so kind of like more open in the palate. But yeah, they're using that. And they're not real. I mean, the crossbite's not relapsing. We're getting the joints in the right place, and
they don't have the systemic issue anymore.
And often, a lot of them haven't even needed a phase 2 of great practice.
Gosh, you guys are like literally a step ahead of me on these questions. Yeah. That's hysterical. I was going to say, when you finished, have you seen that very few of them, or I should say more of them than you would anticipate, don't need a second phase?
Correct.
Right.
Yeah. And some of my orthodontic colleagues, and I was told this through my residency by faculty, I was told this when I was in practice, don't get the teeth too straight in phase 1 because then they won't need a phase 2. And I'm sure you guys have heard that. And it always, before I even was doing a lot of earlier treatment, because again, I didn't come out knowing all of this, come out of my residency, that bothered me. I'm like, but I wouldn't do that to my kid. Like I would not, no matter what, I wouldn't make my kid's teeth stay ugly or unattractive or unaesthetic just so I could then do more work on them later. Why would I ever treat someone else's child that way, especially with the psychosocial impacts, which we're not even talking about, but I saw huge psychosocial impacts with these younger kiddos that I never anticipated seeing when I did treat them early, in a positive way, obviously. And ultimately, I said, we just have to think about this differently as a profession. Instead of, and I wish, and I'm doing some things trying to work on this, but if we could get insurance, because sadly, the treatment follows the reimbursement. I say all the time, if orthodontists got paid to treat younger, I can guarantee you there would be more early treatment going on. I can guarantee it. But that being said, it's not the case. And you hear all the time orthodontists say, oh, don't burn out their ortho benefit. You're just wasting their money, and then they won't be able to afford phase 2. The mentality should shift. In my practice, what I did is, and I trained people to do this, I charged more for phase 1, and if they needed a second phase, I lowered that way down. Right. And I charged because I was doing more. I like to use brackets and wires, and I was developing these arches and growing them and working with airway and uncovering all these issues. And that's more than just the colleague down the road who was putting an upper expander in that kid, if anything, turning it for a couple of weeks and hoping things were going to get better. I was providing a much more comprehensive treatment, so I billed accordingly. Sure. When you do that, you're not worried about the money because it's like I'm getting reimbursed very fairly for what I'm doing early. And if they don't need a second phase, all I would do is just bill them for a set of retainers when all the 12-year-old molars erupted, set of retainers to wear nights only. And that was it. And the parents were like excited beyond belief because they're going, I got another one that's going to need treatment, and my older one's going to college. And this is the best news ever that they don't need anything. So has that been your experience as well?
Yeah, you do the right thing, and it just, you get more patients because of that. I mean, those they'll bring their other kids, and then they tell their friends. And I mean, so, it's not, just doing the right thing, everything else will fall into place, right? And I mean, look, I have a patient who I just worked with, a maxillofacial surgeon friend of mine, because you go through the history, and I got all of her previous records. She was class 2. They put her in class 2 elastics, had a herpes appliance, had teeth extracted, and comes to me with an anterior open bite and a really, the profile, and I look at it and I'm like, she has idiopathic condylar resorption. Before I even take the films, that's what's going to be. And so now she's had to have both condyles replaced. She's 26 years old, both condyles replaced, maxillofacial. She's doing much, much better now. But, what could we have done so that she didn't have to go through that?
Yeah.
And it's frustrating. You see the cases and you look at it and I'm like, I know what the story's going to be. And it's just like, how do we make it stop happening? And like I said, when that white paper came out from the AAO, I mean, they could have taken this whole thing by the reins. They could have put all of those, companies that were making clear aligners that you don't need a doctor for out of business by saying, we can make these people better. Come to us, and it's just, they can still do it. And it's just
well, they're releasing an updated version shortly. I don't think by the time this comes out, I don't think it'll be out yet. And I sadly don't have high hopes. I submitted a manuscript to the AJO-DO that was very comprehensive, written with 28 of us as co-authors. We had deans of medical schools, dental schools. David Gozals was previously referenced as one of the authors. We had sleep physicians, boarded sleep physicians, people in pediatric cardiology from Stanford, Harvard. And they wanted nothing to do with it. It was 301 references, 4,000 word special article.
And with what you did, how do you argue with that? The science, it comes down to it. It's like, what's the argument? So the argument is outside a court of law, because inside a court of law, it'll be a whole different story, right?
They literally, yes. They one reviewer, who I have a feeling I know who this gentleman might be, based on some of what was said, was just completely. The things that he said were literally, when the sleep physicians read his responses, they're like, he doesn't even know how wrong what he's saying is. So we have an orthodontist who thinks, we'll say he or she, but I'm pretty sure it's this gentleman, I'm thinking it is, knows more about airway and breathing and sleep than sleep physicians at Harvard and Stanford, and Jerry Simmons in Texas. And, people are just brilliant in this arena. And that's the sad part, that the editor-in-chief believed that person. Now, in fairness, the other reviewer was raving about it, said it's exceptionally written. It was a masterful piece that had strong positive sides, had a couple minor revisions, and they were really well done. I was really impressed by this individual, that they took the time to read it so thoroughly and made a couple suggestions, which we all in the group believe should be modified. And the editor-in-chief's summary was, now he didn't, now you would think, if you got two reviewers with such opposing points of view, what would a good editor-in-chief do? They'd have a third reviewer. Right? They'd call someone else off the board and say, look, I'm getting like I got A and Z. I'm as far apart as we can be here. Can someone else review this thing? No, the response was that the suggestions would require so much revision that they're not even going to give us a chance to revise the piece. Yeah. So I tell you this because the orthodontic establishment will continue to push this, at least for the time being. I have gone on record saying, I think this will take down the profession if they don't wake up. I really do, because the people get it. Public gets it, right? There's only so long the orthodontists can kind of rest on their laurels and say, well, we're the orthodontists. We're the ones who know. Time's going to tell. And unfortunately, the
sleep arena is going to be a very dangerous place. If you had people from Stanford where sleep medicine was born, right? What's your argument and seriously going to be about it? And when you look at it, you're talking about, you look at a medical history and, people write depression. Do you know what the number one comorbidity for sleep related breathing is? And in the journal, I'm based on over a million people, depression and anxiety. I read it, and when I read the article, I was like, oh my God, because we always go with cardiovascular, diabetes, right, thyroid issues, and all this other stuff. It's and then it's like, well, you look at it and you follow how those things go along, and it's like, I have a patient now that's come to me with she has moderate sleep apnea, and you go through when the problem started, and it's right as ortho's ending, and it's just like, I'm like, oh my God, and she came to me, and I'm like, we're talking about it, and I'm not going to say that anybody did the wrong thing, but at the same time, this is where you are. And she's the one who's saying to me, everything that you explained to me and everything I've read, it doesn't make sense what happened to me. She's like, and she's doing so much better. And it's just, our patients are what's important. And when I initially tried to do research at one of the universities I went back to, and they said, well, what do you want to prove? And I said, what do you mean, what do I want to prove? The whole idea is that I want to prove whether I'm wrong or right.
Right.
And so I was like, I can't work with you, and I mean, it's amazing. And we've let things go by because, there are certain groups that push certain things, and this was allowed. You're just a general dentist. You don't know this or that. I mean, I look at that. I want to go to the smartest person. I want to know the person who's reading the most, who puts the pieces together and can explain it to me.
And if they didn't learn it in their residency and you went through all this other education, we're all dentists. And if the orthodontists aren't learning it, then it doesn't mean it doesn't exist. Right. And on that point, and I want to actually hear your thoughts on this, when the one reviewer, the main criticism was that mouth breathing is essentially no big deal. And that's why I think I know who the person is, because they've written an article on the fact that mouth breathing is not a big deal. Mouth breathing is no big deal. Why? And that it doesn't relate to sleep disordered breathing, that it's like not a thing. This is not true. Mouth breathing is a part of the spectrum of sleep disordered breathing. It is the initial indicator, the canary in the coal mine, so to speak, and that we should be aware of this. And it has all sorts of other issues, as we talked about in David Gozel's study and Carrick Bonnick's study and the Isaiah study. And there's so many studies that talk about the implications of only mouth breathing, which we quoted. And again, this piece wasn't a piece to recommend early orthodontic treatment for everybody. We didn't even talk specifically, get into really detail. It was more just to raise awareness and help people screen for the signs and symptoms of sleep-related breathing disorders in children. Like, that was really the point of it. It was just like, let's just raise awareness and get it all down on one page, why this is important for people to just have it on their radar. So what are your thoughts on that when a lot of the orthodontic community says we shouldn't worry about mouth breathing? Chronic mouth breathing, obviously not acute, but chronic mouth breathing.
My head's going to explode here a little bit. Right. So number one, ADA 2017 paper comes out and says that we really should be looking for sleep-related disease. All right, we'll put that one to the side. I could think of at least 10 articles off the top of my head that show how mouth breathing in children leads to other malocclusions and problems. So, and it's in huge studies. There was the one that was
even the monkey study from the 80s.
Yeah, but this
gentleman who wrote the article in AJODO that I'm referencing, he said that monkeys, this is how incorrect he is. He actually said in the article that monkeys are obligate nasal breathers. They are not. They are preferred nasal breathers, just like humans and other primates. And meaning, because if they're technically by definition an obligate nasal breather, then when Harvard plugged their noses with silicone, they would have died. Right. Because they would not. Rabbits and horses are obligate nasal breathers. Monkeys are not. So this is the type of thing that gets published in the AJODO. Blatant falsehoods. I mean, just literally blatantly false.
Yeah. There's a journal where it's a fantastic graphic where they show what happens with mouth breathing and what it leads to with nasal. You have nasal constrictions. Everything basically leads into mouth breathing. And once you have mouth breathing, you follow two paths where you're going to have the high vaulted palate rolled in and the malocclusions that occur with it. And that huge numbers on that one. And then what was the other one I was just thinking of? It's just so far off from what's happening. But how I just don't understand how you can stand on that when the literature clearly proves you wrong. In peer review,
they said our literature was wrong. Wow. Literally, they questioned it and said or they questioned the sample size or the type of study that was done. Because as you both know, obviously, you can find something wrong with any article. There's no such thing as a perfect study. And I always find it interesting that the studies that people will quote as to why airway is not a thing always are perfect. The studies that say that it is a thing are always very flawed.
There's a British text from 2005. It was written by Lumb, L-U-M-B, and he talked about retrognathia and micrognathia and how it forms in children. And basically, they didn't call it obstructive sleep apnea. They called it sleep apnea hypopnea syndrome there. And he was talking about how it's interesting when you see these things with not being able to breathe and not being able to use our respiratory dilator muscles because of adenoids and tonsils, how it leads to mouth breathing, and that this is an interesting case that, it's setting the patients up for sleep apnea, hypopnea syndrome in the future. And that's 2005, right? And then you go forward to, it was a Korean study that I was talking to about mouth breathing. I mean, I don't see how you can stand on that. I mean, if that's going to be your main defense, I mean, it's like you almost want to publish the day that article comes out, publish that paper in public, in a newspaper or something like that.
Well, yeah, we're not done. I mean, we're not giving up. This is a very resilient and durable group, and we're only reinvigorated. And, it's interesting because there are people in the group and other people that said, don't even bother with the AJODO. They said they're not going to accept it. There's no way. And, I said, I want to give them a chance. I want to give them a chance. I'm an orthodontist, not only by name, but at heart. And I believe that, as you both have said, the orthodontists are in a really unique position to take the lead on this. Mm-hmm. And I said, I want to give them a chance. And if they do what I think they're going to do, which is reject it, then let them. And then we know, right? Then when we go elsewhere, we put our heads on the pillow at night knowing we gave the orthodontic community a chance to see this. And I really feel badly for the other reviewer who really took a lot of time and energy to review this piece and gave such great feedback. And that was just totally discarded. And they just totally went, it shows there's an agenda, obviously. That being said, why do you think things like, and I mentioned the bruxing before, so to kind of wrap it up, what are the things we can think about and see in these patients? Like you mentioned bruxing, Jeff, and you were mentioning the narrow arches, Jill, in the young kids. Like, what are the things that you see in a patient diagnostically? Because I really do believe that's where this falls apart. Mm-hmm. I think a lot of this, and you both have said comments that make me think, may feel similarly on that we're not taking the time to ask why and figure it out in those early visits. Mm-hmm. We're just jumping into treatment. So what are some of the things that you can say? We can start with Jill and then go to Jeff, that when you see in patients, Jill on the younger side and Jeff on the older side, that when they walk in the door on that new exam, what should people be looking at just to start to think a little differently about this?
Sure. Look at their arches if there's crowding. Look at their palate if it's vaulted. Look at their tongue. Does it have, I'm sorry, I'm forgetting.
Scalloping.
Scalloping, thank you. Mm-hmm. Venous pooling, dark circles on their eyes.
Yep.
Look at their noses. Look at the nares. Look at their eyes. Look at their symmetry or asymmetry. Look at their maxilla. Does it look protruded? Look at their mandibles. Does that look protruded?
Frenum.
What am I looking? Frenum. Yeah, I always check their frenum.
Because that's
right.
huge. That can tell you a lot about what's going on in the joint.
And then I also, of course, discuss with parents. I have them fill out a sleep questionnaire. And
oh, great. Which one do you like? Do you like PSQ? Or?
The pediatric Epworth, is that the one?
No, you
use Epworth sleepiness?
No, you don't use it. You use
I don't remember.
Michigan.
The Shervin one. Shervin's PSQ.
Yeah. Okay.
It's peer-reviewed and tested.
And the parents, for the most part, no. They're like, my child never sleeps. Ask how they sleep, not if they're sleeping well, because they don't necessarily know that. But are the bed sheets all a mess in the morning? Are they restless? Are they waking up a lot at night? Do you hear snoring? Do you hear possibly they're gasping for air? Are they getting chronic ear infection? I mean, we could go on and on. What do their lips look like? A lot of parents come in saying, I see their mouth breathing, or their mouths are open. Yeah. I'm sure I left something out. But
congestion in their lips.
Chapped lips. Yeah.
I call it chapped gums when the anterior gingiva is very hyperplastic and thick and dry. Another big one I find is adherent plaque on the anterior teeth.
Sure.
Right? You'll get those kiddos, and you look, and from a plaque score perspective, the posterior teeth don't have that much plaque buildup. Right. Across the upper incisors, it's like caked on, and the parents are like, Doc, we get in there and brush, and it just doesn't come off. That's a telltale sign. And what's interesting is, of everything you've mentioned, which I agree with, we haven't talked about teeth yet, right? We haven't talked about, and that is so perfect that you explained it that way, because when I teach residents, I say the first thing they want to tell me when they come to me with a patient is what molar class they are, or how the overbite or overjet is. And it's not that those things are irrelevant. There's so much we need to look at beyond that. right? In terms of to see and treat with a whole health approach. So yeah, I appreciate all of that. And I would add to the behavioral side too. So some of the, the nocturnal enuresis, but also the ADHD like symptoms.
I mean, you can see when they're all over the place on the chair, pressing all the buttons. I have to have signs up. Please don't press the buttons.
Right. Right. And sadly in orthodontics, we're taught that means that patient, and I've had orthodontists literally in the clinic in residencies, colleagues say this to me, when you get a 5-year-old doing that, the orthodontist will say after to me, that patient's not ready for treatment yet. They're not mature enough. They think about, right? It's the exact converse of what it should be. Well, maybe, and again, I realize ADHD can happen without sleep issues, but maybe that child's acting that way because they're chronically sleep deprived and they have sleep-related breathing disorders or sleep-disordered breathing. And that's why they're acting that way. So thank you. And then Jeff, with you, what are some of the main things you see when you see some adults coming in that you tend or could advise people that these are things that might point more towards an airway-related problem?
Right. So you start with medical history right off the bat. We talked about anxiety, depression. We talked about cardiac issues. We talk about thyroid, right? Thyroid. I mean, you remember when you started in practice, how many people had thyroid issues? And then you think about today, how many people have thyroid issues? Yes, we test more for it, things like that. But that's going to be one of the main things our body goes for when we have an airway issue. Then getting into it, similar things that Jill talked about, look at craniofacial types of things, eyes, ears, level. You get into the mouth, there's obviously scalloping, coated tongue. What does their occlusion look like? Where facets? There are people who don't necessarily brux, but they'll clench super hard. Look at their masseters. I mean, obviously we're doing muscle exams, so I'm looking at all the muscles of mastication, and we're going to see, what happens in those things, what's going on. I look at posture. I look how they walk down my hallway. I look how they sit in my chair. Do they have a head forward posture? Do they roll in? Do they talk a lot? I only ask yes and no questions. Can they not give me an answer because of the higher sympathetic activity, which is maybe indicative of a sleep issue? So for me, I'm doing more of a game of what are the compensations and what's going on, and do they play a role? But again, I'm not telling my patient, oh, you have this. I'm saying in my, hey, I noticed these things, and in my patients who have these things, they also have X, and see if they're interested in having that conversation. And, it's exciting to me that you are involved in doing these things. I mean, there are a lot of years where you sit there and you're just like, I'm like, my first couple of conferences that I spoke at when I'm talking about it, and people are looking at me like, well, this is dentistry, man. What do you, and it's like, I'm like, yeah, I get it, bonding agents and stuff like that. That's all a lot of fun. I'm like, but we're affecting human beings. I mean, the stuff we can do is so cool. And then, you get to a point where you start to just say, all right, I'm going to do what I'm going to do. But it's exciting to me that, hearing that you wrote this paper, that there are challenges out there, because that means that everybody is having an effect in a much bigger way. And that, to me, that's just really, really exciting. And that's awesome. I really appreciate that.
You're welcome. Thank you for the kind words. And so I love to do this. You take a lot of bumps and bruises doing it. And Jill, you said earlier, you can't care what people are going to say and think, because you have to keep the greater purpose in mind. And my greater purpose is patient health, and especially for me, pediatric airway health, as well as eventually healthy adults and adult airway health as well. And not everything's an airway problem, but way more things than people realize are airway problems.
That's right.
And, and it's we have to be looking for it. Before we finish, I want to say I just read, interestingly, there's a new drug in FDA, it's in phase 3 trials. They've done 2 huge randomized double-blind placebo-controlled trials on a drug. It's going to be called AD109, and it's potentially going to be released this year by Apnimed. Released in 26 or early 27. It'll be a once daily pill, and it's a fixed combination of eroxybutynin, which is an antimuscarinic, and a norepinephrine reuptake inhibitor. So it has the norepinephrine reuptake inhibitor as well. And they're saying that it's going to enhance the neuromuscular signaling to the upper airway dilator muscles, especially genoglossus, and reduce pharyngeal collapse. But what are your thoughts on some of these things that are coming out that we're going to be faced with because sleep medicine is getting to be such a big thing?
Yeah. Well, I'll let you, because you do adult sleep medicine.
Okay.
We're not giving kids those medications.
I mean, you think about
God. If we do what we do, Jill, if we can do what we're talking about, hopefully they won't need this. But anyway, right?
So, we have the nerve stimulator, the hypoglossal nerve stimulators with the Inspire and things like that. But now you have a medication, but you have to think about what that medication is going to do, right? Because it's going to do things to affect the respiratory muscles, but what other things does it affect? Because it's going to affect everything that are along those pathways. So
I agree.
There's good and bad to that, and there's always side effects.
Always.
But maybe, on the good part, it means that people are looking at sleep more,
Yes.
Obviously, I think, our country sometimes that people would rather take a pill than do the work. And I think that we need to maybe look at those things. One of the people that teaches at my PIT course is a doctor of pharmacology, and we have him talk about all the different medications. And he talked about this last year, about this medication that you're talking about.
Interesting.
And he's like, it also is going to affect X, Y, and Z.
Yes.
He said, which are not good things. And he said, so now they're going to come out with, he said, then you're going to have to take these medications to counteract those.
Effects.
So great.
I agree.
It's taken care of. And now you have all these other things. So you're not treating the root cause. And if you don't treat the root cause, the problem still exists. I mean, we make oral appliances for people, or you use the CPAP, which is fine, but we have not changed the anatomy of our patient. We're still dealing with their incorrect anatomy.
Band-Aids,
what Jill does and what, you do orthodontics, you are changing the anatomy. And
yes,
that is curing a problem. I'm treating a symptom and trying to maintain the problem, right? I'm not curing sleep apnea. I'm treating it. So, but that's, look, drugs are great. I mean, I'm not going to jump on taking a drug though. I mean, I would rather treat the problem. I have sleep apnea. I wear an oral appliance, and I've had nasal surgery, and it completely changed my life in good ways. So.
Yeah, I'm with you. I completely agree. Super exciting that it's getting the attention, and maybe look for patients who can't do anything else or can't afford it, and better than having the comorbidities, and if it could help at least get them to a better spot where they could function better to then do the work, which we know takes time, whether it's doing it orthodontically with something like MARPI or orthodontic surgery or whatever it's going to be, get them by, and so they can have a better quality of life in the meantime. But I'm with you. I think relying just on the pharmacologics to just treat these things, they're not treating it, they're treating the symptoms, and ultimately you're going to have side effects with this as well. And that was my instant thought. They talked about one of the side xerostomia, which would perfectly make sense, and then insomnia, nausea, and I'm like, well, if they have a higher incidence of insomnia, now we got another problem here. And I don't know the numbers that were suffering from that.
You've got antidepressive medications that you're given because we're not getting good sleep, but then they affect stage 3 sleep, and so now it becomes this cycle. And okay, tonight take this to go to sleep. So I mean, I'm with you. I think chasing this pharmacologically is a bit of a fool's errand, but there's a lot of money there, right? Not as much money in what we were talking about in terms of the education and the proactive. So, well, before I let you go, please both tell the audience how we can get in touch with you, find you, learn more about you, your practice, anything you're doing too with Pittsburgh, and any of the courses or anything. Please feel free to mention any of that. So our website here is Hindin Center at
we work together.
hindincenter.com. So we're in the same place. You can find Jill and I here. We're in New York. The PIT program, if you're interested in that, they can go to the University of Pittsburgh Continuing Education program. It's actually given by the University of Pittsburgh, where I'm an adjunct professor with my good friend John Tucker. And it's a year-long course where we go everything about what we were talking about, from diagnosis through treatment, and the doctors will be patients so that you understand what your patients are going through, meaning you're taking sleep tests, et cetera. And it's a great course because we didn't want it to be a weekend thing. There's no way you can treat the discussion we were having in a weekend.
I'm probably biased, but I did take the course and it was really good. It's a lot. It was actually a lot of work. I had to study a lot, which was good.
Yeah, there is a written exam, and then there's you have to do an oral exam as well when you have to present cases.
And you have to treat 4 or 5 patients.
And you have to treat 4 or 5 patients. If you pass that, then you have a chance at being a diplomat in the American Academy of Physiologic Medicine and Dentistry, with the American Board of Physiologic Medicine and Dentistry, where we talk about collaboration. And the other thing would be to, if you want to learn more about the American Academy of Physiologic Medicine and Dentistry, you can go to aapmd.org. And we have our big meeting that's actually going to be in Pittsburgh this year in May 15th and 16th. We're going to have a lot of the people you were talking about are going to be speaking at our meeting. Trying to just teach things and get more people aware and get better treatment for our patients who deserve it.
And camaraderie. It's always nice meeting other people that are in the same field and like-minded and can have discussions, feel supported.
Yeah, that community is huge. So I'm happy to put links to all that up in as well, and love what you guys are doing with AAPMD. And thank you so much for coming on the show, for sharing all this. I went a little longer than I'd anticipated. I appreciate you guys. I was just loving I was loving the conversation and the feedback. And as you were alluding to, having these discussions with like-minded people, that's my purpose with this show, is just there's so many docs out there that are isolated and they think like we think, but they think they're on an island, or maybe they're getting hard times from their colleagues. I'm sure you see it all the time. And I have so many people when I go lecture or speak, they come up to me and they're like, it helped me realize I wasn't alone. And then I shared it with another person who was like, hey, wait, we're thinking the same way. And it just helps build that community. So I thank you both for what you're doing, not only in your practices and for your patients, but what you're doing to teach it on a bigger scale. It's really awesome.
Thank you.
Awesome. Thank you.
Thanks for what you're doing.
Yeah.
Oh, I'm happy to. Love doing it. So Dr. Jill Meyer, Dr. Jeff Hindin, been an absolute pleasure. Thanks so much for joining me on the show. Appreciate it.
Thanks for having us.
Thanks. Take care.
Thank you.
Bye.
Bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.